I think there might be general agreement that it is somewhat difficult to present a clear account of 4 years of work upon a controversial topic, a new surgical approach to the treatment of mental illness, in 10 minutes. In an attempt to accomplish this task, I would like to read an abstract from a paper scheduled for presentation to the Harvey Cushing Society at its annual meeting in St. Louis, Missouri on April the 19th, 1966. I will then illustrate its content and add as much to it as time allows. The abstract will read as follows. Quote, "The beneficial effects of interruption of cingulate fibers upon certain psychiatric illnesses have been well documented over the last 20 years by Cairns, Lewin, Poole, and Lebeau, among others. These surgeons have, however, preferred a direct attack upon the cingulum. In 1961, Foltz and White presented to this society, that is the Harvey Cushing Society, a series of 16 patients suffering from intractable pain, in whom lesions were placed in the cingulum by stereotactic electrode placement for the relief of pain. Using a slight modification of their technique, we began in 1962 an investigation of this procedure for the treatment of mental illness, primarily manic depressive psychosis. To date, 51 psychiatric patients have been operated upon 75 times. 10 have had cingulotomy performed for the intractable pain of incurable cancer. There have been no operative or postoperative complications. No patients have to date suffered undesirable alterations of personality or intelligence. 36 of 40 psychiatric patients, followed 3 months to 4 years postoperatively, have shown varying degrees of improvement. And in 30, this has been useful improvement. 7 of the 10 cancer patients have had satisfactory pain relief. That's the end of the abstract. Now, if we may have the illustrative material. May I have the first slide, please? This is the area under attack, the limbic system. More specifically, the cingulum. This fiber bundle, the cingulum bundle, seems to be the main link between the frontal lobes and the limbic lobe. The latter is thought to be, in animals at least, a prime regulator of behavior and emotion, if I may be permitted to use the term emotion in respect to animals. May we have the next slide, please? A word about technique. Bilateral burr holes are placed 9.5 centimeters posterior to the nasion and 1.3 to 1.5 centimeters to either side of the midline. Specially designed number 17 ventricular needles, insulated except for the distal centimeter, are inserted into the ventricles and air is injected. If the ventricular needles have pierced the cingulum appropriately, they are withdrawn until the bare ends lie in the cingulate region, and then irradiation is carried out. May I have the next slide, please? Initially, the lesions were placed 2.5 centimeters posterior to the anterior tips of the frontal horns, and you can see the needles in the cingulum in this slide. This is according to the method of Foltz and White. Experience and a suggestion from Paul Yakovlev, a very famous neuropathologist, has induced us to select a target 4 centimeters back of the tips of the frontal horns in our more recent operations. Using a radiofrequency lesion generator, a current of 8 watts is applied to the electrodes for 60 seconds. 2 contiguous lesions are placed vertically in each cingulum. May I have the next slide, please? This is a whole brain section stained by the Loyez method. It has been taken at about the locus of our lesions and is presented for orientation purposes. The shaded areas show the area of the cingulate destruction. May I have the next slide, please? This is an example of the destruction produced. This brain section comes from a man with intractable pain who died from his lung cancer. Note the relatively large size of the lesions. We believe that adequate destruction is vital to surgical success. 10 cancer patients with severe pain have been subjected to cingulotomy. Adequate pain relief was obtained in 7 for periods up to 3 months. Our main purpose, however, has been to investigate cingulotomy as a method of treating the mentally ill, and the remainder of my remarks will be concerned with 40 psychiatric patients who have been followed 3 months to 4 years after their last operation. And let me have the next slide, please. These are the major symptoms of the 40 psychiatric patients. 34 are thought to have had a severe mood disturbance of the manic depressive type. In 6, the diagnosis is in doubt. All of the group have been treated with talk and medicine. 39 of the 40 had preoperative electroshock therapy. Note also that 35 of the 40 were totally disabled. That's the second line in that slide. These patients represent a refractory 5% of the total patient load at the hospital which had been treating them. May I have the next slide, please? This chart shows the age at onset and at operation. We have been dealing mostly with a younger group of patients, many of whom might have been called schizophrenic by other psychiatrists, and all of whom represent a difficult treatment problem. Our youngest patient was 15, the oldest 80. The average preoperative duration of illness was about 10 years. May I have the next slide, please? Now, these are our results. The 8 patients called well are currently symptom-free. The markedly improved group are functioning effectively in society, although psychiatric supervision and some form of treatment are still necessary. The improved patients are still disabled, but at the time of the presentation of this paper, they do not require hospitalization. The slightly improved and unimproved require no further categorical delineation. We might try to excuse this lack of useful improvement on the grounds of errors in psychiatric diagnosis, improper lesion placement, inadequate lesion size, and so forth. But I will resist this temptation. May I have the next slide, please? This is a comparison of the results of surgery for mental illness as recorded by different observers scrutinizing different operations. The degree of improvement is about the same in all 3 groups and is surprisingly similar to that reported by Agassiz Moniz 30 years ago. In his first article, published in 1936, Moniz stated that 14 of 20 psychiatric patients subjected to frontal lobotomy were better postoperatively, and that 5 of the 6 failures occurred in patients suffering from schizophrenia. In one respect, however, and I refer you to the last column, in one respect, however, the cingulotomies and singulectomies are different from the leucotomy series. The operation seems to be much safer. Now a word about multiple operations. 10 of the 40 psychiatric patients have had more than one operation, and 1 patient has had 7. His IQ remains about 130. In this latter respect, I want to make it clear that I do not believe that singulotomy can turn a moron into a genius. But it is true that of 9 patients who had cortical function tests before and after operation, none was worse postoperatively, and 6 had slightly higher scores. May I have the next slide, please? This short bibliography has 2 virtues. The articles listed are excellent in themselves, and they also contain copious additional references for the serious student of the subject of operative attempts to influence the course of mental illness. In conclusion, then, we have carried out 85 bilateral cingulotomies on 61 patients. 10 of these operations have been for pain, and we have been able to confirm the findings of Foltz and White that cingulotomy is of value in controlling otherwise intractable pain. 75 of these operations have been done for mental illness, primarily those conditions characterized by profound and chronic disorders of affect. 30 of 40 patients followed 3 months to 4 years after operation have shown useful improvement. These good results could be due to chance, to the so-called non-specific effects of surgery, or to other factors than surgical intervention. Naturally, we prefer to think that there is a specific operative effect, but we have no concrete proof of this. The operation does seem to be safe, however, and this despite the fact that our lesions have been large. We believe that it is necessary to destroy the most medial cingulate fibers bilaterally and have reoperated patients to be certain of this destruction, as well as to enlarge the lesion. Finally, and most importantly, I as a neurosurgeon do not believe that this operation is a panacea for mental illness, not even for affective disorders such as manic depressive disease or psychosis. Cingulotomy should be considered an incident in the total treatment of the severely disabled patient, and any neurosurgeon who performs it will be disappointed in his results unless he is able to work with psychiatrists who will treat these patients intensively before and after surgery with all of the chemical and physical agents available for the biological approach to the therapy of mental illness.